One, two, three. Hi, guys. Welcome back to When the Pharmacy Closes podcast. I'm one of your hosts, Clarissa.
And I'm Chris.
And go ahead and tell them what we're going to talk about today, Christopher.
Well, okay. Well, that was quick.
Just jump right into it.
So we have an exam coming up this Friday. By the time y'all hear this, it'll be in the past. And hopefully we pass, but we're going to foreshadow that we passed.
We passed. And I just want to I just want to mention, that I've been doing so much better this semester.
Woo!
I've passed the first two tests so far. So I think we'll pass the midterm.
Well, I think we will pass the midterm. And on the midterm, we're going to have some topics like diabetes. We're going to go over like BPH, some erectile dysfunction, and like a little bit of like overactive bladder, urinary incontinence. So we thought it would be kind of a fun episode to kind of hone in on the pharmacy student thing and kind of show y'all with some cases. It'll help us study too, but kind of go over some cases for diabetes and kind of show y'all what the pharmacy student mind, how it kind of works through a case to decide treatment options and stuff like that.
Yeah, like our thought process. And I just want to say, our professors that listen to this, I'm so sorry.
We apologize if we make a wrong decision.
But we're learning, okay?
We are learning. I will also say that when I'm looking at like the cases I have pulled up, we have the answers. So if we're wrong, we'll know.
Okay. I just wanted to say that.
We'll
Shout out
be
to all our
including-
professors. Everybody give them a round of applause.
Whoa! They did a good job teaching us.
Yeah, they did.
Honestly,
I feel I really grasped these subjects.
I feel pretty good with diabetes.
And BPH and all those.
And then watch, we're going to do this and like bomb it.
No, we're not.
No, we're not. We're not.
All right.
Let us get into the first case. Ready?
Yeah,
Yeah.
I'm ready. I
Sounded
think.
hesitant.
I'm scared. What if I'm just thinking for a long time? The people are like, dang, she really don't know her stuff.
And that's when we merge two clips, so the gap isn't as long.
Okay.
Aye. Anyway, so first question. A 71-year-old man with known coronary artery disease comes to your office for a routine visit. He was diagnosed with coronary artery disease 17 years ago after experiencing an anterior wall myocardial infarction, requiring 4 stents in the left anterior descending artery. It's a lot of detail.
I know. You're going to need to move your iPad to the center here so I can see.
So you can read it. So his ejection fraction has remained at 60% since his MI. Other history includes asthma, hypertension, and type 2 diabetes. He says he has no symptoms of chest pain, palpitations, or shortness of breath with exertion or type 2 diabetes-related end organ symptoms.
Okay.
He's currently taking amlodipine 5 milligrams a day, aspirin 81 milligrams a day, losartan 25 milligrams a day, metoprolol 12.5 milligrams twice a day, rosuvastatin 10 milligrams a day, and extended release metformin 2,000 milligrams a day.
Ooh, so he's maxed out on that
He is
metformin?
maxed out, assuming it is the ER.
Okay. Assuming it is ER.
He takes his medications as prescribed, is following a heart-healthy diet, and does not smoke. His LDL cholesterol concentration is 67. Last year, his hemoglobin A1C was 6.1%, and this year it is 6.7%. His estimated glomerular filtration rate is 70 mLs per minute. His physical examination is unremarkable. The next most appropriate step in this patient's pharmacological management is to add, and then the answer choices are basal insulin, 10 units a day, sitagliptin, 50 milligrams a day, empagliflozin, 10 milligrams, or glimepiride, 1 milligram.
Okay. Put it here in the middle.
Let me put it in the middle because that was a lot of detail.
So we could do it step by step, and I'll tell you the things that are like popping out at me first.
All right, so go ahead
Okay.
and start for us.
So we mentioned that, here it does say, he's on extended release metformin.
Oh, I literally read it.
It's okay. He's on extended release metformin, 2,000 milligrams a day, and that's the max dose for ER. Another thing that stands out to me is that his A1C did go up a little bit, and it's almost like at that point. Because I think if they have that type 2 diabetes, it's less than 7% A1C, and it did go up just a
Yes.
little bit. His EGFR is pretty good, so the metformin is okay.
Right, because EGFR or metformin is contraindicated if an EGFR is less than 30. We can go a little more into detail about why that is in a little bit.
You can go into detail. And then I guess just his medications, he's on amlodipine is a CCB. Okay, I was like, please tell me I didn't say that wrong. A CCB, he's on aspirin, he's on an ARB, a beta blocker, a statin, and then metformin, the biguanide.
So I think it's a good start so far. I think a good start to any case is to see what they're on and make sure everything is like optimized per se. Like, is it at max dosing if it has to be? And are they able to be on it? For example, we looked at the metformin to make sure that their kidney function is okay, that they can still be on it.
And then it says that he was diagnosed with coronary artery disease and he experienced a myocardial infarction. So I guess that's like where alarm bells should start going off in your head a little bit. Oh, he required 4 stents. Dang, I don't remember you reading this. I guess my mind was just kind of...
I was reading kind of fast. It was a long case, so I was just trying to, go for it.
Okay, so what do you think the answer is? I'll tell you what I think my answer is, but I don't know. Do you want to go first?
So let me look at the case a little more.
Okay, I have my answer. Maybe we can,
have
on the
mine.
count of 3, we can say 1, 2, 3, and then say our answer.
Like the answer choice? Like A, B, C, D?
Yeah, just the
Okay.
letter. And
Okay.
then we'll read the answer choice like
And then
fully.
explain our rationale.
Okay,
Okay, ready? Come on, same
Right.
answers. Same answers.
I know. Ready? 1, 2, 3, C.
Yay!
Okay, if you didn't know, C is empagliflozin, 10 milligrams. It's an SGLT2 inhibitor.
So let's go over like why we got that answer, and we got the same answer. So first we looked at the metformin to make sure that they can still be on it. And the reason is because metformin is a medication that is completely renally excreted. It's
Yes.
excreted unchanged. But part of the mechanism of action of metformin is that it decreases the glucose absorption in your stomach by turning it into lactate. So
Okay, Mr. Metformin. Metformin Mormon.
So it's turning it into something that won't be absorbed. But the problem with that is that, let's say your kidney function isn't good, metformin relies on the kidney to get out of the body. So if
Yeah.
your kidney function is not good, it's not going to get out of the body, and you're going to be making a lot more of that lactate. So you're at risk of lactic acidosis.
Wow, look at you. So the one thing I remember, I don't know if we learned it in PALS, was that the metformin is like excreted in the waste. When
yeah.
there's like a chance of a ghost tablet.
Please explain what that is.
It's, I don't know, is it just like the out of the shell? And it just like comes out whole in your poop.
Yeah, so I think a lot of times the way extended release meds are made is that there's some sort of capsule, I guess you can picture it, that just, it controls the rate at which like the drug is metabolized in the body, used up, whatever, you know what I mean. And basically that capsule will show up in your poop.
Yeah. I think a funny story, I hope Dr. Padilla listens to this, is when she said that her patient like brought her a little container of poop. They were probably like, why is this happening to me?
I mean, I admire the patient. They were pretty concerned enough to do that. So, you know what? Watching out for their health. That's pretty good for them.
Woo. Okay. So that's why we chose, wait, what were we talking about?
So we had talked about the metformin, which I want to point out something, too,
Oh, okay.
but we were hopefully going in the same track. The med we always hear with diabetes is metformin.
Oh, yeah.
It's either metformin or insulin. Those are the two we always hear. And usually it is a first line. As you can see, this patient was already on metformin.
Yeah.
But we did mention they're already maxed out on it, so they need some sort of other agent.
Okay.
There are other instances where metformin is not the best first line.
Me remembering, we try to remember and wish it's not good.
Do you want to go a little into that?
I guess the only things I remember is the EGFR less than 30. And you want to be careful in IV contrast. I forgot how long you should wait before.
I believe I know the numbers were 24 hours and 48 hours. I think it was 48 hours after and 24 hours before. It's that or the reverse. I
okay.
don't fully remember.
And that's all I remember.
And then something else. So I know you had also mentioned when you were reading the case that you looked at the coronary artery disease. So that is something part of ASCVD.
Oh, okay, yes.
So ACVD is kind of, it's a characteristic a patient can have, showing that they've had some sort of like vascular condition, or they're at risk of some sort of vascular condition, and that can be like a stroke, it can be coronary artery disease, it can be a heart attack. There's a good list of what it can be. But the fact that they have some sort of history of that, or they're at risk for it, changes our first choice of medication from metformin to something else.
Yeah, so usually metformin is not first for that, right?
Mhm.
So let's go through all the answer choices and why we did not see those fit. Okay. So basal insulin at 10 units per day. I personally didn't choose that one because I felt like their A1C wasn't high enough for that. That's the only reason I did not choose basal insulin.
I agree.
Okay. Sitagliptin. I think sitagliptin is a DPP4. Yeah, honestly, I don't know why I didn't choose that one.
Though I know, I mean, to be honest, when it comes to the exam purposes, and like in this case, I just don't go with DPP4s because I know they don't have the best efficacy.
Okay.
And I know, like Dr. Belia kind of pointed out, the MVPs and DPP4s were not one of them. So it's usually not one that I'll go for.
Okay. And glimepiride is a sulfonylurea, also known as...
You got it. You got it.
Do I got it?
It's a fun word. Secretagogue.
Oh, yeah. Insulin secretagogue.
Basically, it means that it stimulates insulin secretion. It's squeezing the pancreas to get more insulin out of it.
But I also feel like that one wasn't appropriate.
I think because of the ACVD pointed out, the SGLT2 inhibitor, which empagliflozin is FDA approved,
For that.
on top of diabetes, on top of a few other things that maybe we'll get into with other cases.
Yeah.
But of all these choices, the empagliflozin was the best option.
Okay. Let's check our answer.
Watch us be wrong. It's loading.
We
And
were
we were
correct. And then it just gives like a little explanation, but
That-
I'm pretty sure we just gave that
Yeah,
explanation.
I don't care to read it. Do you want to read the next one?
I sure will.
Go for it.
See. Okay. The next one. A 63-year-old man comes in for an annual health maintenance examination. He was last seen 3 years ago. He has a known history of a pituitary microadenoma treated with bromocriptine, resulting in normalization of his prolactin levels and stabilization of the microadenoma. He also has type 2 diabetes, for which he is taking metformin 500 milligrams twice a day. His history is otherwise unremarkable. His physical exam is remarkable for body mass index, BMI, of 43. His vital signs and the rest of his examination are unremarkable. In routine laboratory tests performed 3 years ago, his hemoglobin A1C was 6.7%, consistent with 2 previous measurements 4 and 6 years ago. He currently has no symptoms of his type 2 diabetes. Yet results of the laboratory test he ordered today reveal a hemoglobin A1C of 14.4%, a random blood sugar of 322 milligrams per deciliter, and a prolactin level of 4.1. 4.1. Normal is 4.0 to 15.2. The next most appropriate step in this patient's pharmacologic management is to add
I already know my answer.
A. Basal insulin 10 units per day. B. Sitagliptin 50 milligrams per day. C. Empagliflozin 10 milligrams. Or D. Glimepiride 1 milligram. I think I know my answer. Should we say it at the same time?
Yes.
Ready? 1, 2, 3, A.
Yes. Okay, so A was to start basal insulin 10 units per day.
The only reason that I chose that was because A1C is set at 14.4. And I think,
You read that and I was like, oh my.
and I think and his random blood sugar is over 200. And he's not symptomatic, but those 2 blood tests, I think, already give him the diagnosis.
Yes. I think the blood sugar parameter is over 300, which it is still over 300 because it measured at 322. And then if their A1C is over 10, that's an automatic indication to start insulin.
And his prolactin level is barely above, but I don't remember learning about prolactin level in class.
I think for the purposes of ISBP, it was not super important, at
Okay.
least in terms of diabetes.
Yeah, so basal insulin, I was like, yep.
Yeah, so that's one of those cases where they may, for example, they are on the metformin 500 milligrams BID. That's initial dosing. However, usually you would maybe increase the dose.
Yeah, because metformin lowers A1C from about 1.5 to 2%, but I don't think that would have done anything for his A1C at this point.
I definitely wouldn't have gotten
I mean, it would have
to
lowered
goal.
it, but yeah, not into goal.
For those who don't know, the goal is less than 7%.
What is prediabetes? I think prediabetes is 5.4 to 6.7.
Close. You mixed up the second two numbers.
Oh, no.
It's 5.7 to 6.4.
Are we sure? Okay, so 5.7 to 6.4% is prediabetes. Okay.
So yeah, this is one of those cases you would kind of just jump for the last line.
And we kind of already went over the other answer choices in the previous. Okay, let's see if we're right. We're correct.
Yeah.
We're
You see, we
two.
remember this stuff.
We're 2 out of 5 right now.
2 out of 5. Nice.
All right.
Okay, what's the next one? I think maybe the question could have differed a bit by giving us all insulin choices, but maybe giving us different amounts.
Oh, like rapid acting, short acting, like that?
Maybe, or even giving us different daily units.
Okay. I
Because
see.
in that case, we do also have to know how to calculate total daily dose.
Oh, do I remember how to do that?
It takes me a little thought to differentiate it between if we're doing a combo of like short acting and basal, or if we're just doing basal.
Okay.
But I believe if you're doing a combo of short and basal, you're going to do, that's the one that was 0.7 to 1 if it's type 2 diabetes and 0.5 if it's type 1. And then you split that in half. Half of it's basal, half of it's bolus. It sounds complicated, but it makes sense when you're looking at the slide.
When they give us practice problems, it makes sense.
Anyway, next question. Okay, so the next question is a 66-year-old man with a history of type 2 diabetes, hypertension, and hyperlipidemia presents for a routine follow-up. He's maintained on extended release metformin, 2,000 milligrams a day, and is tolerating this therapy well. In addition to metformin, he's taking aspirin, 81 milligrams a day, and atorvastatin, 40 milligrams a day. His LDL cholesterol is 67 milligrams per deciliter, and his hemoglobin A1C is 9.4%. He has no other signs, symptoms, or diagnostic studies suggesting end organ complications from diabetes. His physical examination is otherwise unremarkable. The next most appropriate step in this patient's pharmacologic management is to add, and it says insulin, NPH, empagliflozin, or liraglutide.
Ooh, they give us the options on this one.
They did give us the options, and it's going to
Right.
be a toss-up.
Can we put it in the middle?
Oh, yeah.
The water bottle sound. Okay. Well, his A1C is just a little tad bit
Just
high.
a wee bit,
Um,
but it's not high enough.
he's on I believe, a high intensity statin.
What
Yeah.
dose is he on?
40.
40 for atorvastatin? Yeah.
Okay, I was like, please. Is it 40 to 80?
Yes.
Okay. He's maxed out on his metformin. Okay. How much does he weigh?
one, I don't think we have that information.
Oh, okay.
This one might come down to which one is more effective in lowering the A1C.
Let me start thinking.
I know you need to think about that. I think so. Empagliflozin, the SGLT2s were,
Point.
I think it was 0.8 to 1.2.
Yeah, 0.8 to
percent.
1.2. Liraglutide,
That's a long,
long
acting.
acting, so it's 0.5 to 1.5.
I think it's 0.8 to 1.8.
Oh yeah, 0.8, and then the short acting are 0.5 to 1.5. So
Are they both at starting dose? So that's something else we have to know. We have to know starting doses and max doses.
empagliflozin. Which one is that one?
That one is Jardiance.
Oh yeah, Jardiance.
I think it is at
10, mhm.
Yeah, so 10 is initial dose.
This one is not.
Liraglutide?
No. Oh wait, that's Victoza, huh? Oh, never mind. I was thinking it was Trulicity.
Yeah, liraglutide is 0.6 and maxed out at
1.8.
1.8, right? Okay. And then empagliflozin's maxed out at. Oh,
Wait, I have the chart.
is
right
it also
here.
10?
Hold on, let me see. I think it might be 10.
I think it starts at 5 to 10 and then it maxes out at 10.
Empagliflozin,
Bottom.
25.
20. Oh, okay. Did not get that right. Sorry. Anyway, so maybe does he have any sort of kidney problems? We don't have that information. Hyperlipidemia, hypertension, LDL, A1C.
We know EMPA gives us ASCVD benefits.
That's
So
very
does
true.
liraglutide.
They both give it to us.
Hmm.
Empagliflozin, no, this guy has no signs of heart failure, no signs of CKD.
I would say liraglutide.
I want to say liraglutide too because
GLP-1.
just more effectiveness.
Watch it be one of the insulins.
I know, right? We're
Okay.
saying it's between empagliflozin and liraglutide, just based on the fact that they're both FDA approved for ASCVD risk. And we think it just comes down to which one is going to do better at decreasing his A1C.
Okay. Should we just put it?
Yeah. So liraglutide. Let's see. What? Oh, we're right. Okay.
All right.
What is the reason it gave us?
It's GLP-1s is preferred to insulin when possible. This recommendation represents
Yeah, it says GLP-1 agonists as a class have a greater glucose lowering effect than the SGLT2 inhibitors.
we're looking at
Go
the right
us.
stuff.
Whoa.
Okay.
Next one.
Did we read that question? We did, right?
We did.
Okay. Okay, this is question 4 out of 5. Hey, we're kind of going through them fast.
And we're getting them all right.
Okay, this one. A 72-year-old man with uncontrolled type 2 diabetes. Ooh, now you have the shivers. Visits your clinic for a routine follow-up. He has had several and organ complications from his diabetes, including retinopathy, neuropathy, and nephropathy.
He got them all.
And Charcot joins for when he sees nephrology, ophthalmology, and a podiatrist routinely. Oh, he does see them routinely. Okay.
Okay.
His comorbid conditions include hypertension, dyslipidemia, recurrent lower extremity cellulitis, and edema. His physical exam is remarkable for BMI of a 41.4, a blood pressure of 140 over 72 millimeters of mercury, and a heart rate of 64 beats per minute. He has a bilateral leg edema with evident Charcot joint in his left lower leg. His hemoglobin A1C levels have fluctuated between 9.2% and 11% over the past several years, despite despite maximum pharmacological therapy. He asks you about bariatric surgery. The best advice you can provide him concerning bariatric surgery, I feel like this isn't in our line of expertise.
Yeah, I'm gonna be
Let's
be
see.
real honest. I don't know the answer to this.
Okay, let me read the answer choices, and then this could be a fun one to
We can
guess.
take a wild guess.
A, bariatric surgery is associated with a lower type 2 diabetes remission rate than medical treatment. B, bariatric surgery is associated with a higher type 2 diabetes remission rate than medical treatment. C, bariatric surgery is no better than medical treatment. Or D, the results achieved with bariatric surgery are independent of the amount of weight lost. Yeah, I
Okay.
have no clue.
Okay, wait. So bariatric surgery, if I'm not mistaken, can be something like bypass, right? So it could
think-
be like decreasing the size of the stomach.
Mm-hmm.
So I'm trying to think glucose absorption associated with lower type 2 diabetes.
I
Remission
want to
is
say B.
why?
Well, you said smaller stomach. This is higher type 2 diabetes.
See, I kind of want to say that just because, well, remission means like they go into a controlled state, right?
Oh,
Right? Relapse is when they go back into it.
oh yeah. Right. So then this one, A.
I'm gonna go with A. I kind of want to say B, but I don't know.
Okay. I say A, which is bariatric surgery is associated with a lower type 2 diabetes remission rate than medical treatment.
I say B, bariatric surgery is associated with a higher type 2 diabetes remission rate than medical treatment.
All right, let's see which one of us
We
is
just
right.
want to point out this is not our scope of practice.
Yeah,
Or
we're
at
just
least
guessing.
Not yet.
Yeah, we're just guessing.
Nothing Lexicom can't answer, but we don't got time for that.
Ah, you're right. B.
Wait, but why? It says it says in a recent study, obese patients with type 2 diabetes were treated surgically and followed for 10 years are more likely to experience remission. But why?
Yeah, I don't know.
Does it say it right here? No, it literally gives us no reason.
Well, you were right. Good job. Last question.
All right, 4 out of 5. Let's do number 5.
I'm not 4 out of 5.
Yes, you are. In my
Okay.
heart.
Okay, in his heart.
Okay, ready?
Go for it.
A 61-year-old woman with type 2 diabetes and diabetic renal disease visits your office for a follow-up after recently having laboratory testing done. She's had type 2 diabetes for 16 years and 3 years ago was noted to have persistent albuminuria, which is being treated with lisinopril that was titrated to 80 milligrams a day. Her eGFR is 43 mLs per minute, down from 70 mLs per minute 18 months ago. Additionally, her hemoglobin A1C is 7.8%. She takes sustained release metformin 1,000 milligrams a day, atorvastatin 40 milligrams a day, and lisinopril. Her physical examination reveals a blood pressure of 136/77 millimeters of mercury and a BMI of 29.4. Her examination is otherwise unremarkable. The next step to prevent a sustained decline in eGFR would be to add, I already know where I want to go with this.
We'll read the answer choices to
Okay.
the people.
So it could be add dapagliflozin, 10 milligrams a day, subcutaneous once weekly injections of semaglutide, losartan 50 milligrams a day, or basal insulin 10 units a day.
Okay. Should we say our answer on a count of 3?
You got it too?
I hope so.
All right, ready? One,
1,
two,
2,
three,
3,
A.
A.
Yes.
Yep.
Okay. Why?
Um,
The
well, she has renal disease.
That was the first kind of red flag that popped up in my head.
I don't think she's not maxed out on metformin.
Sustained release, I believe.
That's
is-
ER.
You're right. So that's not maxed out yet.
Atorvastatin, she's on a high intensity statin. I mean, her A1C is almost at goal.
It's almost there, but I mean, the question does word it in a way to decline her eGFR declination rate.
Yeah.
So I think
Dapagliflozin.
simply based on the question, an SGLT2 inhibitor, because that's the only one that is FDA approved for CKD.
Okay. Let's just see if we're correct.
Woo!
Whoa!
5 out of 5. 5 out of 5.
Oh, sorry for all the headphone users. I just kind of screamed into their ear.
What's the word? I forgot the word. There's a word for it.
I don't know,
I forgot too.
but I'm sorry.
Awkward.
I am so sorry. Well, that's good. I guess we do remember stuff from diabetes.
I feel a little more confident for the exam, not gonna lie.
Yeah, me too. It's because I was telling Chris that the other day I was trying to review all the material for diabetes, and I feel like I couldn't remember anything anymore.
It's very meticulous. Like if we were to just make a general list of what we have to know, like it's the drug names, generic and brand. We have to know
Starting
initial and max
doses,
dosing.
max doses.
We have to know their efficacy, like how well they drop the A1C, when to use them, when not to use them.
Precautions, contraindications.
Sometimes even depending on which professor is asking which questions, sometimes even like down to the cellular level, what is happening with these medications.
But I feel good.
I feel good too. I think we did good. It was like a little studying thing. And I hope y'all kind of see, going into ISBP, if you're a P1, kind of seeing the way your thought process has to start looking.
Yeah. I don't know, before we end this episode, do you want to give some like study tips?
Okay, so studying definitely varies by the student. I know a lot of us study in different ways. For me, for example, when it comes down to like mechanisms of action, I have to draw it out. And some like the professors do give us diagrams kind of explaining how things work, but sometimes they can be a bit too complicated. They show more the whole cell than they'll show just what's happening. And myself, if I draw it, it kind of commits it to memory. And
His drawings are actually quite good.
Thank you.
They're so cute. Look at that picture.
And so, and then other than that, I also make charts. So in terms of like all the diabetes medications, you heard us talk about SGLT2 inhibitors, you heard us talk about GLPs, about thiazolidinediones didn't come up, but those, insulin. It's a lot of meds to know for one disease state, so I'll do charts.
His charts have helped me so much because he kind of like puts everything on. I guess because they give us so many slides, it's kind of hard to study like throughout the whole slide set, I guess. So when Chris does his charts, they help me so much because I could just focus on like one page or one chart where all the information is. And I personally have trouble like putting it all into one. So when Chris sends it to me, I'm like, thank you. Thank you, Christopher.
It does help putting it all in one place because I mean some of the slide sets are like the complicated disease states can be like 100 plus slides and it
I
can be
know.
really intimidating. But to put it like you kind of pick and choose what's important and put it in one page, maybe two max, and it I don't know, it makes it easier, I guess, just having it in one place.
Yeah, I guess you don't get overwhelmed too. But not gonna lie, I saw your BPH chart and I was like,
Yeah, BPH is
it wasn't
not
too
bad.
bad. I guess you just wrote a lot on here, or like the way you formatted it. I was like, what is this?
I would say the bad part about BPH, in my opinion, is the precautions and stuff like that.
Yeah. Honestly, it wasn't too hard either.
We went over that earlier, so we feel good about those two.
And then I guess my way of studying is, well, I started something new this semester. Like if our professors actually record the video, I like rewatch the lecture if I feel like I need it.
Mm-hmm.
And then I'll take my time to like read through the slides as well. And then I use this giant whiteboard at home. I need a smaller one that fits on the table because I feel like the one I use is like hanging off the table.
Is that
I'm
big?
like, yes. It's like one of those ones you hang on the wall, you know?
Oh, yeah.
So I need like a little desk whiteboard or something. But for me, rewriting is really important to me. Like I have to test myself. So the whiteboard has come in handy. I just write what I know. Like say I was talking about the 5-alpha reductase inhibitors. I would write 5-alpha reductase inhibitors and then write everything that I knew about that. And then like in a different color, I'd go in and like fill in the things that I missed. And then I would erase it and then I would try again. So that's how I study.
That makes sense. Kind of like active recall.
Yeah, I need to, or I pretend that I'm a teacher and I'm like, okay, so 5-alpha reductase inhibitors do this,
That's
this, and
the
this.
best way to do it.
Yeah, I have to like teach myself. And then the day before the exam, my sister will test me on all the slides. She'll just go and she'll ask me questions. Like she'll make up questions like you do, and then she'll test me on all the material.
And that's something we'll do. Like between me and her, sometimes we'll have like our friends Christine and Athena will all be studying, and we're just shooting questions at each other, trying to predict like what are the professors going to ask us.
Oh, Chris is so good at predicting what they're going to ask us. And then recently what I started implementing is getting up maybe an hour before I'm supposed to start getting ready. And I just review the slides one more time or like the material.
Really?
Yeah, I started doing that. Honestly, it gives me a little bit more confidence because I'm like, okay, Clarissa, you just saw this in the morning. I mean, maybe like it like sticks in my head. So that's what I've been doing, and it's been helping a little bit. I mean, I'm not meticulously studying in the morning. I think I'm just reviewing reviewing the chart, just looking over what I was kind of iffy on the previous night, and then just solidifying it. So that way, hopefully, if it appears on the exam, I know that I just saw it, you know? So that's what I've been doing.
But yeah, thank y'all for listening to this episode.
Thank you, professors, for tuning us right about these two disease states.
We hope we made you proud.
Yeah, we hope we made you proud. I really enjoyed these two examinations. I feel like I told my mom, I was like, wow, this is what it's like to pass the test and not even have to worry. Like, you know, when sometimes you don't feel too good about an exam. These past two tests, I just walk out, I'm like, I got that.
You walk out with a little kick in your step.
Yeah,
You're
for
like,
real. I'm like, hey,
you
you want to discuss the exam? But yeah, thank you so much for listening. We'll see you guys in the next episode.
If y'all want to see us on YouTube, we're at RX Closes Pod. And on TikTok, we're WTPC.pod.
And then on our Instagram, we're the same as here on Spotify, or the name of our podcast. It's called When the Pharmacy Closes on Instagram. All right.
Thank y'all.
Thank you.
Bye, friends.
Bye.